Okay, we ready to get started? Does anybody ever feel like when you are hosting a webinar or a workshop, it's like being a pilot in an aircraft. You have so many screens to get ready and look at, and you just need to make sure they're in the right place. So let's give this a crack. Welcome everybody to this portable webinar, Visibility, Progress and Hope for Women Living with Chronic Illness. We'd like to start with an acknowledgement. We respectfully acknowledge the traditional owners of the lands upon which we gather. For me, that's the Wurundjeri people of the Kulin Nation. We also want to acknowledge the traditional owners from where you are Zooming, and we invite you, if you want, to acknowledge the traditional lands in the chat. We pay our respects to elders, both past and present, and acknowledge the ongoing impact of colonialism on Indigenous peoples. We stand in solidarity with Indigenous Australians in their ongoing struggle for sovereignty, justice and self-determination. And we also acknowledge the vast inequities faced by Aboriginal and Torres Strait Islander women in Australia's healthcare system, with higher rates of chronic health conditions and less access to the health services they need. So today, when we talk about bridging the gap for women's health, we acknowledge this gap is even wider for our Aboriginal and Torres Strait Islander sisters. My name is Joanne Osborne-Taylor. I'm a lead design strategist in the design services team here at Portable, and I will be your MC today. And I actually feel pretty chuffed about doing that because the Portable women on the panel, who I'll introduce shortly, are not only the panelists, but the masterminds behind this event. And I'm really grateful that they have invited me to participate in this conversation. A gentle reminder before we begin to take care throughout and after this conversation. We will be learning about chronic health conditions, the experience of pain, and hearing stories about medical experiences that aren't as we would want them to be. We might use descriptive language to describe lived and living experiences that are challenging and traumatic. If our conversations today do sit heavily with you, then please reach out to the people who support you and you feel comfortable talking to. And of course, you are welcome to take a break at any time. So, if this is your first time at a Portable webinar, then a very big welcome to you. And if you are joining us once again, then it's great to see you back. If you don't know, Portable is a human-centered design, digital design and development agency based across Australia. And our mission is to seek out areas of social need and policy failure and make transformational change using research, design and technology. So we work with clients in state and federal government, community organisations, not-for-profits and businesses for good to make positive impact in areas like access to justice, mental health and wellbeing, aged care, education, public services and more. And we design alongside people with lived experience, creating and testing solutions together, influencing and shaping those services so they work better for the people who need them. And we regularly undertake self-initiated research and innovation projects to identify areas we think we can make a difference. Our recent submission to the Victorian Government's inquiry into women's pain is one example. Our conversation today is a continued dialogue about the experience of women living with chronic illness and their hopes and ideas about how health and related sectors could change to better support women with pain conditions. And of course, tomorrow is International Women's Day. So we thought it was a great way to have a rich and important conversation about women's health and opportunities to improve the lives of women and girls. After introducing our panelists and touching on some background context, we'll spend most of the time in discussion and we'll leave about 10 or 15 minutes at the end for questions from you, the audience, which you can submit using the Q&A. We do have a number of people joining us, so we probably won't get to all the questions, but we'll certainly do our best. Our colleague Xanthia in the background is our technical support today, so if you have any tech issues, please type them in the chat and Xanthia will get you sorted. So, our panelists, I'm delighted to introduce them, three brave and bold Portable women whose lived and professional experiences have collided and then synthesized into this complex conversation about women's chronic illness, pain, and opportunities for the future. I'm going to start by introducing Aisling Costello. Give us a wave, Aisling. Aisling's work at Portable is as a senior design strategist. She has a passion for projects focused on the health, mental health, and wellbeing sectors, and is cultivating a practice in trauma-informed and trauma-responsive design. Like many of us, Aisling wears many hats. Some of those hats include being a designer and creative thinker and maker, caring for 2 dogs and her partner, who is a human. She's written that in brackets, which was interesting. You needed to point that out, Aisling. Living life also with a whole body chronic inflammatory disease, endometriosis. Aisling's pronouns are she, her. Today she's joining us from Wurundjeri country, about an hour north of Melbourne in the beautiful Macedon Ranges. Welcome, Aisling. It's also my pleasure to introduce you to Beth Hyland. Hey, Beth. Beth is a leader in the design space with over a decade of experience delivering design and innovation projects across a portfolio of 90 plus projects. Beth has a particular passion for work in health and mental health sectors. Her approach to problem solving draws heavily on co-design, systems thinking, and strategic foresight approaches. Beth is a lead design strategist at Portable. She has lived experience of Still's disease and type 1 diabetes. Still's disease. I think I pronounced that incorrectly, Beth. Beth's pronouns are she, her. She's joining us today from Wurundjeri country. Welcome, Beth. And finally, last but never least, Wilhelmina Wallin. Hey, Willie, also known as Willie, is a practice-led design researcher, facilitator and practitioner, working across the social innovation and higher education sectors for over 15 years. She's passionate about making a positive impact through design, engagement, and communication. And she's an advocate for bottom-up approaches to problem solving and building capacity at the grassroots level. Willie is a senior design strategist and has lived experience of chronic musculoskeletal pain. Her pronouns are she, her. She's joining us today from the lands of the Darug and Gundagara peoples. Hey, Willie. Before we start our conversation, I'm just going to touch on a little bit of background. Why are we talking about chronic health and women's pain? Well, women are disproportionately affected by pain in terms of how common it is and its sensitivity, but also in how their pain is viewed, treated, and even researched. Globally, more women report chronic pain than men do. And a survey of over 1,750 Victorian women found 40% are living with chronic pain. Women also experience pain differently to men. And there is some evidence to suggest when diagnosed with the same condition, women are more likely to report higher pain scores than men. They're also viewed and treated differently. Women are more likely to be told their pain is psychological and dismissed as not being real or all in their heads. So we think it's great to see the Victorian government establishing an inquiry into women's pain to examine systemic issues and to find solutions that will be the basis for improving patient care. And our 3 women on the panel want to be part of that conversation. So let's kick it off. I'm going to stop sharing my screen. And panel, I'm going to start with one question for all of you just to warm us up and get us into the moment. And I'll start with you, Beth. What is one reason you're participating in this panel today?
Thanks, Jo. So I am someone who has a real improvement mindset. I'm always looking at how things can be made better, and I'm really fascinated by change. It's probably the thing that drew me to a design and innovation career in the first place. And that includes when I'm going through just experiences in day-to-day life. And one of the things that I know is that even in sectors that are filled with people who are very capable and have good intentions, systems and services can drift towards outcomes that they're not aiming to achieve, and inefficiencies and complexities that are unnecessary. And I think that while I see the health sector as one of those places that really attracts great people, I think there's a lot of room for improvement in services and systems. And so I'm excited by this as a conversation, because I see that as like one of the starting points for innovation and change is really good conversations.
Thanks, Beth. Really looking forward to hearing some of your observations later on. Willie, what about you? What's one reason you're participating in this panel today?
I am really excited about the wave that is happening at the moment in women's health, with the inquiry into women's pain that Victoria is doing, but also much broader than that. I was at a health forum with federal ministers last night, talking about women's health, and it's like this zeitgeist moment, and I want to be behind this wave because for me and for so many women that I know, this has been such a crucial issue in how things are diagnosed, how pain is treated, how you are treated within the health sector, how much extra money it costs for women. It's kind of endless. So I'm very happy to be part of this conversation and to see the conversation growing, because the more that people talk about it, the more connections are made and the more chance that larger systems can be influenced and changed. So that's why I'm here.
Thanks, Willie. A lot of different scales I think we're going to be talking about today.
Mm.
Aisling, over to you. What's one reason you're participating in the panel today?
Thanks for reframing or for reiterating the question as well, Joanne. I was just listening deeply to what you shared, Beth, and you, Willie, and I was like, oh, I really enjoy working with you. I read something last year that I keep thinking about and coming back to. So the scale of this is maybe starting with that individual and then scaling upwards and outwards towards community, society, systems. So I read a statistic that was published by Endometriosis Australia last year in 2023. It might be older than that, actually, now that it was 2021. That's it. And it was that 1 in 6 endo warriors lost their job due to their endometriosis. And I keep thinking about that statistic. I keep thinking about workplaces, environments that are conducive to living with, managing, and perhaps even thriving with chronic pain. And what makes a workplace different from another where thriving is possible or not possible. And I think as designers, we often talk about how important it is to bring lots of viewpoints to the table, to fold those into our work, to bring it into our project processes, our engagements, our outcomes, to shape the outputs that we work on. I think that, and again, reflecting on that 1 in 6, like human-centered design practice is an awesome place for people with chronic pain to work, thrive, and contribute meaningfully, because with the right supports in place from the team around them, and I'm speaking to you leaders if you're here with us, and I'm speaking to you organizations if you're joining us, the people who are in access power to set up and initiate projects. I'm really interested in what happens when the environments are right, where people can bring their lived experience of chronic conditions and chronic pain and fold that into the work and use it to inform the work. So it's not just the outputs and outcomes are informed by our participants that we invite in. There's space for us to bring that perspective too, and for it not to be seen as a deficit, and for us to fall into that 1 in 6, but rather see that number change over time. I'm really hopeful that as an industry, we don't turn people away because of a disease. We actually seek out and find ways to bring them into work, into paid work. That's what I'm really interested in and hopeful for. And that's one of the driving factors that I talk openly about, being somebody in full-time employment that has chronic pain and a chronic inflammatory disease.
It's really interesting, Aisling. Thank you. You're thinking about it not just as as someone with lived experience, but also someone who is working with organizations to help improve their service. And then you're also thinking about it in your own workplace and the workplace of others. So there are multiple levels that this experience of pain, chronic illness, affects different environments. So thinking about your experience as women and designers who also live with chronic health and pain, what would you like to share with us about your lived experience? I'm going to start with you, Willie.
Thank you, Joanne. So I was a roadie. I've done a lot of different things in the past, and I was a stagehand, and that was a lot of heavy work. And I had a little bit of a back injury in my early 20s, and throughout my 20s and into my 30s, I had some little niggling stuff. But then in 2016, my back went very badly, like 2 ambulances to the house badly. One was transport, one had the drugs. You know what I'm saying? It was not good. And so in 2017, I had 2 spinal surgeries. They didn't go that well. I've done a lot of things since then, and this is where the investment comes in around pain. It's Pilates, it's physio, it's all the stuff. It's all the stuff that you do to try to maintain strength and move yourself past something. Then in December last year, I had a pelvic ultrasound, and a very diligent sonographer said to me, "Have you ever been diagnosed with endometriosis?" And I said, "No." And she said, "Oh, well, yeah, okay. So I'm now a suspected case of endometriosis." And now it's like my relationship to pain has changed. And I mean, you know, and all the stuff, perimenopause, menopause, all of that stuff that's surrounding this. But what's been really interesting about, and why I think it's important to talk about lived experience, is because connections are really, really important. Using diagnostics to make connections is really important. And I'm saying this now on behalf of myself, but on behalf of a lot of people that I've spoken to in the last few weeks for a bunch of different reasons. Connections and proper diagnostics and advocating for those diagnostics for yourself is one of the most important things that you can do for your own health, because often it'll be like, and I've had this, should I be getting a scan on my back now? My pain's not improving. Oh, not just yet. Listen to your instincts. And this is what I feel like I'm doing now. It's like I'm going in there and I'm going, this is what I need. This is what is going to help me make those connections, because we're whole people, and addressing the whole person is so incredibly important. And those diagnostic tools are key to understanding what's happening with you. And you have those rights and you have that access. So that's sort of my journey in a nutshell. It's been long, and it's been really, I don't use the word trauma very lightly, but it has been an incredibly traumatic experience to go through that. And if it's one thing that I hope that people take away from my lived experience today, it's that, yeah, advocate for your diagnostics. Super important.
Thank you, Willie, and thank you for sharing your story. It really sounds like connecting with others and reflecting back on some of those key moments that have influenced that experience is really important. And I know we're going to touch on that a little bit later on. Aisling, over to you. What would you like to share with us about your lived experience?
Oh yeah, where to start? I think I was reflecting on this, and I was thinking about, you know, as we were collaborating and trying to figure out what our questions would be, and where do we start with these conversations for today. When I was looking at this question, thinking about it, what really stood out to me is it took me, so building on what you've mentioned, Willie, it took 15 years for me to get a diagnosis. And endometriosis was mentioned to me, you know, about 5 years into that 15 years, but there was no follow through. It was just mentioned, and I didn't know what to do with that. And now and again would think about it, but I didn't have the tools or the resources or the information to know, oh, I need to do this and then this and then this in order to get towards diagnosis. And I think in that time, because I'm adrift and unsure what to do with this information that's been tossed out, oh, it could be endometriosis. I've developed some pretty unhelpful thinking traps that I reckoned have instilled in me an instinct to perhaps internalize ableism or contribute to stigma. And I've been doing a lot of work around identifying and unlearning those things, but most importantly, being aware of them so that I know when it might show up. And if I think about how that impacts my work as a designer, how that might show up as bias or blind spots when I'm synthesizing research, when I'm writing a discussion guide and curious about asking specific questions, when I'm creating outcomes for research to try and achieve, or building prototypes to test hypotheses. To give you something tangible, one of the thinking traps that I reckon has shown up the most is comparison. And that's mostly comparing myself of the Aisling you see today with the Aisling of the past. That was a lot more action Aisling. Today I'm a lot more, I need to rest very frequently because I have a lot of pain in the fetal position Aisling. And some of the things that I'd be thinking when I'm in that space are, I felt worse, so I can get through this. I'll put off doing the thing that I need to do to manage my discomfort, my pain, my poor mental health, or my, plummeting mental health sometimes. And that kind of has evolved into, or can evolve into, I'm not who I once was, and lamenting that and going through the process of grief post-diagnosis, because I'm not Action Aisling anymore. I'm this new Aisling. I don't have an alliterative word for her anymore. I need to discover that. The takeaway that I want to share with you is, I reckon prolonged wait times for diagnosis, where ideas are flown about, but there's no follow through or support. And that's diagnosis of underlying health conditions. They have affected how I see myself in the world. And that in turn affects my thoughts, which affects all aspects of my life. So designers, if you're bringing me in as somebody with chronic pain into a project, and you're asking me about, would I use this app? My answer to you is going to be, no, I am too busy with the cognitive load that it takes to manage my pain. Remember to pull myself out of thinking traps, reframe the world around me, and then live my life. So the thing that I want to get across is just awareness of everything that we're carrying and thinking about, and perhaps some space and grace, and asking us the questions where we can meaningfully engage in that app that you're trying to test with us. Yeah, does that start to answer your question, Joanne?
It does. Thank you. Thanks, Ash. That was great. A number of things kind of stood out to me. 15 years to a diagnosis, that's significantly affecting, your quality of life. But also you talked about, this feeling of drifting, thinking traps, like comparing to, I felt worse, so this is manageable. And also that experience of grief. And I just, as a designer, I start to wonder, how do you consider those things when you're designing health services? Beth, I'm going to go to you on this one next, and I'm particularly thinking about how gender relates to your lived experience. What would you like to share with us about that?
Yeah, thank you, Joanne. So I guess, as was mentioned in my introduction, I have two different autoimmune conditions, type 1 diabetes, which I've lived with for 16 years. And that's not a pain condition particularly, but it's something that's taught me a lot about the healthcare sector. And in some ways, I have seen that as good training for the second condition that I've got, which I was diagnosed with last year, which is Still's disease. It's a rare condition that has some similarities to rheumatoid arthritis, which people might be more familiar with. So it's a condition that can become life-threatening, which it did in my case. And pain in my joints, muscles, and skin has been a significant kind of part of the symptoms of that condition. I also want to say that when I think about the challenges that I've experienced in the healthcare system, it's really hard to sometimes pin down the causes of these experiences. I think, there's an interplay of different factors that always influence, whatever experience anyone individual has going through the healthcare system. And it's things like limitations of the system, and sometimes like getting the sense that resources are really stretched. Sometimes it can be limitations in medical science and what medical science can actually do. And then I think, things being gender-based and discriminatory, I think there's good research to show that can play into it too, even though as an individual, it's pretty much impossible to know when that's happening. The only thing I can say around that sort of the gender link, I think, is that I have definitely had experiences of having my pain being minimized or dismissed, and maybe in places that you wouldn't expect, including by female health practitioners and in a hospital setting as well. So I think that's kind of the link back to gender that I would make. One last thing that I just want to point out on the lived experience front is that it's really fascinating on this panel, Willie, Aisling, and I all have different origins of our like pain conditions, like musculoskeletal endometriosis, which is an autoinflammatory, and mine, which is a autoinflammatory condition. So it's really interesting that there are connections and things we have in common, and a lot of what Willie and Aisling is saying is resonating really strongly with me, despite the fact that the medical origins of our conditions are different.
And I think if we kind of put that layer of gender you're talking about, there are limitations to what medical science can do, but we're also talking about limited research that's specifically looking at the needs of women. And so that plays out in the experiences that you've all had. So I'd love to turn now and talk about what challenges you've encountered around health services. We've talked about delayed diagnostic timeframes as one of those things, but what other things have you encountered around health services in your journeys? Willie?
This is really interesting, actually, because when my back went really badly, and just to explain the level of pain, it's like if any of you have been through childbirth, there's a rhythm to it. Nerve pain, disc herniations, there's no rhythm to it. It's the most excruciating pain. You can't get comfortable, you can't move, you can't walk. It's and I went to a doctor, a GP, prior to that, and I said, look, I really want to get an MRI done on my back and find out what's going on. He said, oh, people come in here, they can't walk. It was just dismissed, and then I couldn't walk. So I went back to the same GP. I only went back to him, mind you, and this is a systemic issue, because I couldn't get into my GP, because GPs in regional areas where I live, and lots of regional areas, and even sub-metro areas, it's almost impossible. So that's a bigger systemic issue. But then what happened was that I went back a few days and I said, I want the MRI. And he went, oh, okay, but let me put you on this drug in the meantime, which ended up another whole story. But anyway, so I went and they said, yep, you've got a 10 millimeter herniation in your disc. It was compressing on the sciatic nerve. So I still do have nerve damage down my left leg. And because I'm a public patient, I had an extraordinary wait time. And I was hoping that it would fix itself in the wait, but it didn't. So what was really interesting about the series of things that happened was that at every step of the way, the area itself was treated. It's a very myopic look at your body, at your person. It's like this little thing. And after the second surgery, I didn't get a period for 3 months. And I'm like regular as. So this was very unusual for me. I know my body, and I knew that this was unusual. When I finally did get one, it was so excruciatingly painful that I took 2 Valium and went to bed. And I'm not a drug taker either. So it was like really extraordinary for me. I saw my surgeon afterwards and I said, look, this is what's going on. And he said, oh, there shouldn't be any connection. And even in my head, I was thinking to myself, why wouldn't there be a connection? Like, it's not like these things, this is your body. Of course it's connected. So I felt in that moment, there's no point continuing this conversation because it's not going to go anywhere. And what's happened since is that in the last 12 months in particular, the increase in hip and back pain has been extraordinary, and to the point where I'm starting to lose the ability to go for long walks or do anything. It has these flow-on effects. So it comes back to that relationship you have with your health practitioners. And I don't think that you should have to advocate so strongly for people to look at the whole you, but you do. And if you're a person like me that goes, oh, okay, I get the picture on this, I'll just try other things. But what if you don't have other things to try? And that connection that you make with the one health practitioner that's going to listen to you or not and treat you like a whole person or not makes all the difference. And it's really a matter of going, okay, women's pain is complex. We have a whole bunch of reproductive organs in there that play havoc with us. And was it endometriosis all the time? I don't know. I don't know about those connections, and I can't think back to that. It's unhelpful at this point. But what happens now changes, and it changes how I interact with the health profession and the things that I advocate for myself and the conversations I'm having with other women. It's mind-blowing what's coming out for a lot of people. So,
it's really interesting, really, this kind of idea about whose information is available to them, and this idea of looking at the body and trying to stop things from getting worse rather than waiting until you actually need higher levels of care. What you were talking about, I was just reflecting that a couple of months ago I had to have a bone density scan, and my doctor came back to me and said, it's totally fine. You don't have osteoporosis. Don't worry about it. And then I went to my chiropractor and he said, well, let me just check the report, looked it up and said, oh, no, you don't have osteoporosis, but you do have osteopenia, which becomes osteoporosis and still unless you start doing strength-based exercises and take some supplements. But my obstetrician had not shared that information with me at all. So how was I to know that I needed to make some changes in order to prevent myself having a condition that would cause a lot of pain?
And that's empowerment too, isn't it?
Yeah.
It's like,
yeah.
get
And
the
that
information is power.
Yeah, whose information is it? It's my information. It's my body. What about for you, Beth? What challenges have you encountered around health services?
So I might share a little story from my experience. So one of the symptoms that I experienced with Stills is an autoimmune rash. And it's really hard to explain what that rash feels like. But if you imagine, if you've ever rolled in like hay or grass or something like that, and it's given you kind of like a prickle under your skin, it's like, imagine that, but sort of like times 1,000 and in lots of different places on your body, because it was quite systemic for me. And that was a real experience of like discomfort, but I really struggled to find language to communicate how bad it was and what that unpleasantness felt like. I remember saying to one of the health practitioners afterwards that I also had like a mobilizing body pain. So there were periods of time where I'd lie still because there was I couldn't move because it hurt too much. Like staring at a glass of water and being like, I'm really thirsty. I really want to drink that, but I'm just in too much pain to move. And I would take the immobilizing body pain over the rash pain any day. And that was like, a way that I learned to communicate that this is actually like my discomfort is very strong here. And it's been really interesting having conversations with others and kind of realizing that part of the challenge with getting the relief or the care or the treatment that you need is about language and about the ability to have a meaningful conversation with a health practitioner about what's going on for you. And sometimes that's about being able to articulate your experience. And I feel like, I'm someone who's quite privileged in a lot of ways, have a really solid education. English is my first language, and it's hard for me to do that. And I really feel for people who might have English as a second language or some additional challenges that make it harder to communicate. And I wonder about ways that it can be faster and easier for people who are experiencing symptoms and people in the healthcare who are providing healthcare to get to a better shared understanding of what's going on. Because I even think that like pain and things like a pain scale is a really simplified and quite blunt instrument to understand what somebody's experience is. So yeah, I think communication and the ability to articulate and get some shared understanding with someone else is so important.
Language and that shared understanding. Thanks, Beth. Aisling, what about you? What experiences have you had? What opportunities do you see, particularly around pain and gender?
What you've just shared, Beth, really resonates with me. So I am very grateful for, and also want to acknowledge that I'm very privileged to have encountered some very talented and engaged and aware pelvic floor physios. And for me, pelvic floor physio and clinical Pilates are strategies that work for me and how my endometriosis presents and my symptoms. I want to emphasize that and make really clear that everybody who experiences endometriosis has a highly individual experience. There are shared moments that matter across our journeys. There are shared symptoms, but I can't know your pain and you can't know mine. And we can't know how that interacts with our different systems, our nervous systems, our muscles, or ligaments, or tendons, or bones, or endocrine, you name it. It's a shamazel. And it's very subjective. But what Beth is describing, I've also experienced. And I'm grateful that the pelvic floor physios that I've worked with listened to my language when I describe both the symptom I am having at that point, the stabby jabby pain on my left side, but also how it changes over time. And I would use words and phrases, and they would share back to me, hey, Ash, when you describe, it feels like you're rolling around in a bed of nettles or a bed of thorns. Is that, and then they would ask questions like a deep burning sensation, and they would help me understand that that might be connected to your nervous system and how your pain receptors are receiving information, growing, stretching, and sending it back. I'm doing that a lot. And so I was able, by finding people who could make space for me to describe what matters to me, help me understand what that means from their realm and their space as people who know bodily systems and functions and what change over time looks like. And they know what endometriosis is and how it works and how it affects people. So I see that as an opportunity. So practitioners who listen, who talk with somebody who maybe we could use the language like they have a yarn, they sit and listen and learn with. If they're then able to play back to you what your descriptions mean in their field, I now have information that helps me understand, right, my endometriosis affects my nervous system in these ways, my pelvic floor in these regions, it causes muscle tension in these ways. It is connected to somehow the shearing that I get in my lower SI joint on my left side and the referral pain down my abductors. And I've only been able to paint that biological picture because of working with pelvic floor physios who listen, who validate I have pain, who say it's not okay, and help me find strategies to help me manage it. So I've packaged up a challenge, but also just an opportunity. I really want us to tell more practitioners to do more of, really.
And it sounds like the sort of traditional rating scale around pain, what do you feel out of 10, is far too simplistic. In fact, we've got some comments in the chat there about having those experiences where, you know, you rate something 7 out of 10 and the doctor says, well, you should be in the hospital, but you're not. So each unique person's, you know, context, their lived experience about, you know, influences what they might pick on that rating scale. Lily?
I just want to add, it's so important what you're saying, Aisling. And the other thing, even beyond endometriosis, it's also, there are so many symptoms that are different in women than they are in men, in different presentations of different conditions. I want to give a huge shout out to the girls of Katoomba High who stood up in the health forum yesterday and said, my classmates want you all to know that ADHD presents differently in girls than it does in boys, and we're not getting what we need in terms of diagnosis. They're calling it hormonal, they're calling it this and that. And this was just one instance of from very young women who are just coming into their reproductive life, you know, their cycles and their stuff, all the stuff, you know. It's like being there for young women really early on to engage with them in conversations, but also it's an education thing for practitioners, particularly GPs and, you know, community health nurses, all people that are in the health sector. There are a bunch of stuff that we can do. Even as designers, there's a bunch of stuff that we can do to help make those conversations easier. But lived experience is key to that. And the difference in symptoms for different things and how they present in women and men is crucial to advancing women's health.
Aisling or Beth, I saw your hands up when Willie was talking. You want to jump in there?
You go for it, Beth. I'll hop in after.
There's a point I want to make that I'm not exactly sure how to make this, but I feel like there's something about when people start talking about lived experience as a way to help influence systems and affect change, I feel like there can be a real nervousness around how expertise sort of plays into that. So what I mean is that I think in some ways there has been a little bit of a loss of respect for expertise because of increased access to information. And I think a point that I just want to make is that when you have lived experience of a condition, you try and educate yourself a bit. But I think it's really important to acknowledge that, like, the lived experience of a condition is very different to the clinical information and the clinical understanding of what's going on. And we need the clinical side of things, to help make good decisions. And I think there's no, like, they're different types of expertise, I think, is the thing that I want to express, and that they can exist alongside one another. Because I think the reason that there's like people being vocal with their lived experience is always when there's something being overlooked or neglected or not understood properly. And that knowledge is really, really valuable to inform change. And I just want to like highlight that that can exist alongside a real respect for the understanding that doctors and nurses and health practitioners have, and that really the best change is when those two things work together, because those perspectives are both really useful.
Aisling?
That's really powerful, Beth. It's reminded me of a scenario I had a couple of weeks ago, and I was walking down. Just imagine me walking down Victoria Parade. I'm traveling to see my surgeon to get some updates from some scans and blood tests I've had recently. So because of familial things, we're also keeping an eye on some other stuff that could impact me in the future. I am very keen on proactive care. And as I was walking down, I was trying to remember all of the dot points that I wanted to talk to with my surgeon about. And I really like my surgeon. I have had good results working with them. They know their stuff. But I had to, once I got into the session and remembered my dot points, I had to remind myself that I am going to see this person for a very specific reason. And what I am starting to feel as I am talking with them is a bit of distress. And I need to remember that this is not the person that I lean into and rely on to help me navigate that part of living with a chronic condition. I don't mean to reduce my surgeon's expertise, but I'm like, I go to them to cut really well. It is one of the things I go to them for. I don't go to them to support me in my mental health as I'm experiencing this. I communicate clearly in that session how things are landing with me, and I confirm that I will be having a conversation with my support network, which at the time included like my partner, some friends who are aware of what's going on for me, and a mental health professional that I'm very privileged to have access to, as well as that surgeon, as well as a physio and an empathetic GP. That is a group of 6 people in my support network. I am an outlier, folks. Like, a lot of people don't have this kind of support. I'm privileged to be in employment that I can pay for it. And people with endometriosis pay a lot of money to manage their condition. So I just wanted to build on what you mentioned, Beth. There is a place for expertise. One of the ways I manage that cognitive load is going, this is what I go to that person for. This is what I go to that person for. This is what I go to them for. And then I'm able to maybe relieve some of that cognitive load into the hands of somebody who knows what to do with it. I just wanted to share that to reaffirm lived experience is expertise, but so is all of those other people in your care team.
I can also really hear, Aisling, just the level of expertise you've developed in the time that you've experienced your condition, and how you're able to be empowered and advocate for yourself through that process. And it makes me wonder, what does that look like for a young person who identifies as a woman? What does that look like for someone who has a new diagnosis or some new symptoms? Because it feels like it takes a length of time to be able to step into that self-advocacy and be able to understand how to navigate the system and all of those different providers, if you have the luxury of having that team.
Can I jump in to offer?
Yeah, please.
So this question came up when I was listening to and learning with people from disability community, and a very strong voiced, empowered disability advocate leaned forward and said, you might think I know my shit, and I'm really here to advocate on behalf of others, and I've got it all together. But I only am presenting like that today because of all the supports I have in place and the strategies that I've done to get me ready to be here and be present and advocating. And as you were framing that back to me, Joanne, I was like, teenage Aisling is cowering in her boots and crying in a small dark room somewhere, because that is not what I am often. And that is certainly not what I was a few years ago. Today feels like a day to prepare and then be present. But I just want to like demystify that if that's how I'm presenting, that is often not how I am.
Thank you, Aisling. I want to jump, Willie, if it's okay, to questions. We've got a couple. Thank you to our participants, because the first one really touches on that idea of different spaces in which you need to advocate for yourself, but also in which you need a supportive environment that understands your needs. So I'm going to read this one out from one of our anonymous attendees who's been really brave and shared a bit about their experience, and then the question. And they say, I'm living with a bowel condition and have had surgeries and removed my colon, had a stoma, and then now an internal pouch. I also suffer from endometriosis. Gosh, that's a lot, isn't it? We hear you and we're with you. I have also been misdiagnosed or told it's a bout of gastro and period pain is fine and normal. This happened during COVID and I got laid off work a couple of times. How do we protect information sharing with employers, but still enable people with invisible disabilities flexibility without having to explain things like, hey, I'm tired, I want to work from home, I can still be productive? Willie.
I'm going to turn that back to employers, because I think something really significant that has struck me recently, and it's not necessarily to do with me, but to do with people generally living with, especially disabilities or chronic illness that's not visible. The mental load that you carry with that to make sure that everything around you is okay, quite huge. So I would put it back onto employers and say, how are you making conversations about chronic pain, chronic illness, disability an accepted and open and welcome thing? How can you take some of the mental load from people who have so much mental load all the time, and really shift the culture? That's really significant. I would actually put that back the other way.
You want to jump in there, Beth?
Yeah, this is going to be a slightly messy answer, I think. But I think some of the things that this comes back to is like a deficit-based understanding of people who have a chronic illness or condition or disability. And I think one of the things that is really helpful is a reframing to understand the types of strengths and skills that people develop through having to confront things like this. And it might mean that we need some additional flexibility around time, or that there are certain things that enable us to perform really well in the workplace. But I think there's a lot of space to be loud and proud about the skills that we've developed through facing adversity. And I think that doesn't need to mean going into the details of your experience always, but just saying like, I've got a condition, this means that I need flexibility in this ways, but these are the great things that I'm able to do. So for example, for me, some of the things that I think I've learned to be really good at is like problem solving under pressure, communication, resilience, the ability to empathize and be compassionate with others. And some of those soft skills that are actually really important to being a great employee, and things that have been shown to be really beneficial in the workplace. You absolutely develop those things through can develop those things through facing adversity. And I think having a strength-based understanding of what someone with a chronic condition brings to the workplace is really helpful. And it's something that we can talk more about, so more employers sort of share that understanding.
Thanks, Beth. I saw your hand go up there, Aisling.
I was listening, Beth, but I was also finding a way to be succinct, because there's a couple of things that I want to share. So Belinda is asking us in the Q&A channel, thank you for offering your question, Belinda. How do you think we can increase awareness of chronic pain in society to make navigating day-to-day life more manageable? Everybody who's joined us today, listening to these stories is an excellent way to do that. To the anonymous attendee who has shared your story in the chat, number one, I'm sorry that you've had that experience, fellow friendo. Number two, your pain is real. Number three, what you have done is increase awareness of everybody on the call today by sharing your story. So from an individual outwards, that's how we do it. We listen and learn with people, and we listen to their stories, and we validate their experiences are real. I think I really love your reframe, Willie, and I want to, like, in all punk is kind earnestness, want to add to that, hey employers, How are you talking about chronic pain in the workplace? Especially for endometriosis, there are resources on the Endometriosis Australia website and the Kendo website that are how to talk about endometriosis in the workplace and workplace training that you can do. That benefits not just endometriosis, but many different kinds of chronic pain conditions that affect a disproportionate population, women, and we get into marginalized communities there too. I read a statistic yesterday that said that BIPOC women take twice as long to diagnose for endometriosis. So the average wait time for an endometriosis diagnosis in Australia is 7 years. That could be 14 years for women of color. So folks, how are you talking about it in the workplace, and how are you offering supports to people who have chronic conditions? Beth?
Yeah, I'm just coming back to the question we were talking about earlier, sort of reading between the lines. I think I heard something in there about like not disclosing to an employer. And I have a feeling that perhaps this is connected to sort of there's always interpersonal risk when you disclose something about your health, that feels vulnerable. And it's a really interesting thing. I know that the panel, like we had some nervous moments in like sharing openly about this in a professional setting. It's not easy. One of the things that I've sort of learned over time is that disclosure doesn't have to be a black and white thing where you share everything or you share nothing. And sometimes it's about finding a comfortable way to share a little bit to test out how trustworthy someone is as well. So like when you're looking for employment, you could ask a question in your interview about like, is this organization supportive of people who have disabilities or chronic illnesses? And that's not necessarily disclosing anything about yourself, but it's giving you an opportunity to kind of test the waters and see if this is somebody that you want to work with as well. Because I think when you find the right environment and the right people who are trustworthy, it just makes a world of difference.
We're coming up to time. I'm going to go to you, Willie, and then I'm going to ask one last question before
Cool. I'll
we
just be
wrap
really
up.
super quick. I
Go,
just
Willie,
love
go.
what I'm seeing in the chat of people wanting to connect, and I think that's one of the things that we're really hoping. Certainly, I'm really hoping that this is the conversation wave, and I'm just loving seeing that. So, yeah.
Fantastic. And so I just want to, we've got what have we got? 8 minutes left, and a couple of quick slides to get through at the end. But I really want to ask, what gives you hope for the future? What are you seeing that's working? A brief answer from each of you on that. We'll start with Aisling.
3 things. I was introduced to the idea that endometriosis is not a reproductive disorder. Let's sit with that language for a moment. Reproductive disorder. It is a whole body disease. So endometriosis has been found in many of the organs. I think all of the organs in our body. Need to fact check that one. It doesn't just affect our uteruses. It's everywhere. It can grow everywhere. And I think that reframe gives me hope that we will destigmatize that condition. And when I am in a workplace and I say I've got endometriosis, I don't fear that, oh, now I'm going to have to talk about periods and menstruation and bleeding and cycles and hormones and the things that are stigmatized as stuff that holds us back. Instead, I'm going to talk about pacing, energy, thinking about ramping up, high spurts of energy, ramping down. I'm hopeful that that reframe of the classification of this disease is going to help us destigmatize it and make it easier for more people to talk about their condition. And a gentle reminder, it's 1 in 7 Australians have endometriosis. That is a very high number of people.
It certainly is significant, isn't it? What about you, Willie? What hope do you have for the future? What are you seeing that what is working?
I'm loving seeing multiple layers of shifting happening. It was really great to hear last night when I was at the Women's Health Forum that there are really big systemic things shifting in terms of even the way that women GPs are treated and the gender pay gap in GPs, and the fact that they have, oh, you do the women's stuff. Well, it takes longer because it's generally more complex. So, bulk billing changes that allow for community nurses to have independent sort of treatment payment for all kinds of things that you don't really need a GP for. They're practitioners as well. So those sorts of things give me hope. Changes at a really large systemic federal funding, state funding level are great. But what gives me a lot of hope, and I know I've banged on about this a little bit, but these conversations, using language, sharing experiences, and also the recognition that lived experience is so crucial to advancement in health. We've talked about the fact that a lot of research didn't even include women, clinical trials and things like that. Now it's legislated that if you do a clinical trial, you have to have women involved, or a very, very good reason not to. Those are really good things to be hopeful for, because as we've discussed, the symptoms can be really different. The presentations can be really different from men to women. So it gives me a lot of hope, but also on the grassroots, that women are like, hang on a moment, I want to talk to you about something. And it's not just conversations among women, it's conversations among women and men, of all genders, getting in there and actually talking together. That's what gives me a lot of hope.
Thank you, Willie. And Beth, one final comment from you.
I'm going to cheat and highlight one need and one thing that gives me hope. So the need I see in the healthcare system is, I feel like there is a really big gap between hospitals and emergency care and GPs, and there's not enough options in between. And I feel like for people with chronic and or difficult to diagnose conditions, we really need settings that make it easier for people to advocate, make it easier for them to rapidly get a diagnosis and a holistic assessment of their health, and have ways that someone can escalate if things in their condition change. And I think at the moment, the GP and hospital model does not have enough options in it. And that's really what we should be designing and creating, is some more healthcare settings. And I think that would really help. And then the thing that gives me hope is, just in 16 years of living with type 1 diabetes, I've seen drastic improvements, both advances in medical technology, digital solutions that also help, and sensors. That's made a huge difference to my care. And I've also seen a shift in the attitudes and the way that clinicians work with me, which has made a massive difference to my experience as well. Going from a place where clinicians would be trying to adjust your medication on your behalf, to a place where nowadays I find it's much more common that the clinicians I work with will really listen to me, understand my experience, and give me advice in a way that's actually much more helpful. So that fills me with a huge amount of hope that I've seen so much change in just 16 years, which is really a relatively short period in some ways.
A great note to end on there, Beth. Thank you. I want to thank our panelists, Aisling, Beth, and Willie, for their openness today, your vulnerability in sharing your stories, and your foresight and bravery in creating the space for this conversation. Thank you. If you want to know more, there are some links up on the screen about women's chronic health conditions. If you want to put in a submission to the inquiry into women's pain, you want to advocate to your federal health minister. We're looking at facilitating a community event in May to bring service providers, researchers, and people with lived experience together to tackle some of the challenges we've covered today. And Willie, are we sending the survey out afterwards to everyone who attended?
Yes, yeah, we will.
Yep, so
so
we'll
please,
send out
if you could
survey.
fill it out, that'd be great.
Yeah, helps us to gather interest and perspectives from women experiencing pain, from carers and support people. And if you want to continue the conversation with us and want to reach out, I know in the chat you can reach out to us on LinkedIn, or you can send an email to the Portable inbox, and that will get to one of us on the panel. Thank you, everybody, for coming. Thank you to those who shared their own stories of lived experience, and for your kind words and feedback throughout the event. We hope you have an enjoyable afternoon.
Thank you so much. Bye.
Thanks, everyone.
Go well and take care.